this is RN Tracy 2 MD, and today I'm coming back because I wanted to share some tips for the OSCE. And so if you're looking for this channel, I'm assuming you know what the OSCEs are, but for anybody who's not familiar, OSCEs are the formal assessment for clinical skills. And so basically you're going to be doing an oral presentation of your clinical skills. It can be really nerve-wracking, I know, and so hopefully I can help with that. Just a little bit about me in case you haven't seen some of my other videos. My name is Tracy. Hi. I'm in my second year of medical school, and before I was in medical school, I did work as a registered nurse. I also got to work specifically in the CV-ICU, so I do have plenty of experience taking vitals at the very least. And I also got to be a clinical instructor, and I was a preceptor as well, so I've also got to teach people how to do vitals, and so hopefully most of this is pretty accurate for you. And so I've made this video in order to give you a comprehensive overview of how to do your OSCE specifically for the vital section. I'll have a separate video explaining how to do the OSCEs for your history taking section. So this is specifically for vitals, and you can check out my other video if you're interested in history taking. And so just a little bit about my personal philosophy and why I make these videos. So this would be like my first official instructional video. And really when I started this YouTube channel, and also if you see I have an Instagram page as well, I wanted to make sure that I was disseminating information just because I do believe that information is meant to be shared. I don't believe in gatekeeping any type of knowledge. And so if I get some knowledge, I'm going to share that, because what a waste it would be to keep it to myself. What am I going to do with it, right? So that's my whole purpose for this channel. If I have any information about getting into med school, any information about how to get through med school, as long as I've already been assessed on that specific thing, then I'll feel free to share some advice on it. If I haven't yet been assessed on it, then I'll probably not be in the right place to give any info on it. So yeah, that is the plan for today. We are going to be focusing on vitals, and I hope that you are skipping to the proper parts, just because I know I can be long-winded. So feel free to always skip the beginning, my intros, if you don't need to hear all this and you're just like, I just need to know how to do vitals. Skip over. But we're going to get started on vitals, and of course I'm going to have my paper with me, just because, as you know from my last video, I like to have a paper so that I don't get lost in what I'm saying, and I want to make sure I'm staying on task. And also, just before we get started, make sure that you have all your equipment as well. So what you're going to need for your OSCE, of course, you're going to need a stethoscope, right? So that's number one, have a stethoscope. You're going to need your manual blood pressure cuff, and I'm going to make sure I show you how to use this as well, okay? You're going to need an analog watch. So you cannot have a digital watch for the OSCEs. You're going to need an analog watch, something that has the big and small hands there. And then finally, you're going to need a clipboard and a pen. So some of these things might be provided for you, but just in case, these are the bare minimum for what you're going to need for your OSCE, for the first year OSCE at least. Okay. So the first thing that you're going to do when you start your OSCE, so you've knocked on the door, they've let you in, you're in. Number one, hand hygiene. So make sure that this is going to be, if you've ever taken a driving test, you know that you have to exaggerate everything that you're doing. Make sure that you're over exaggerating everything, because you're getting marked on it, right? So you're going to go in, you're going to be very obvious. You don't have to say that you're doing the hand hygiene. Actually, don't say it at all. But you're going to be very obvious with I'm doing my hand hygiene, okay? So that's number one, so your examiner will see. Throughout this entire thing, you need to be talking basically both to your examiner and to the patient. So you're making sure you're providing patient-centered care, but then you're also looking at your examiner to almost ignoring the patient for a quick second to provide information. And I'll explain to you what that looks like as we're going through. And then I'll also be sharing what that looks like. So, I should have said this in the beginning, but what this whole thing is going to be a teach, show, and do. So I'm going to be teaching you the didactic portion right now, and then I'm going to be showing you what it looks like with one of my friends, and then you should be going ahead and doing this for yourself at home, okay? Okay, so that was number one, hand hygiene. Number 2, you're going to introduce yourself and your role. So you're going to say, hi, my name is Tracy, Apiakubi, your full name. You're going to show them your badge, either both to the examiner and to the patient. And then you're going to say, I'm currently in 2nd year, and I've been sent in by Dr. whoever to do a physical exam on you. And then you're going to say, is that okay? Because it's important that you ask for consent as well. And so then you're also, number 2, you're going to be asking them for their name and how they'd like to be addressed, if there's a specific pronoun. So the pronoun is not like completely necessary for this part, more important for the history taking, but it doesn't hurt. So you can throw that in there as well. Okay, so you've already done your hand hygiene, you've introduced yourself, you've asked for their name. Make sure you also ask for their age. So sorry, for number 3, you're asking for their full name and also age, or you can ask for their date of birth. So that's important as well, and I'll explain to you why a little bit later. So number 4, you're going to be explaining what exactly it is that you're doing. And so you're telling them, I'm going to be doing a set of vitals on you, and that's going to include taking your pulse, checking your respiratory rate, and taking your blood pressure. So you've stated all those things, and they're already aware of what is going to be happening, and you can ask for consent again. Is that okay if I proceed? Then you proceed. Okay, so that was the first 4 things. And then number 5, I guess, would have been consent. Okay, the next thing that you're going to do before you even go ahead and do the actual vitals, so number 6 is you're going to do a general inspection. So you're kind of just looking at them from head to toe from a distance. You're having a look at what do they look like, because overall you're kind of trying to assess, are they stable enough for me to continue this assessment, or is there an acute situation going on here? So you're commenting on your pertinent positives and pertinent negatives. And so they've already told you their age. You're going to say they look appropriate for their stated age. They look like they're sitting comfortably. It doesn't look like they're in any respiratory distress, like something, those kind of things, just so the examiner, and these are things you're saying to the examiner, just so the examiner is aware that you're thinking about, okay, is this patient stable or is this patient not stable? Like right on, like first meeting, what do they just generally look like? Also talk about how they're dressed for the weather. Like, are they dressed appropriately for the weather? And that might be like more important when we're talking about hypothyroidism, or when we get to like the psych section. But for the most part, your standardized patients are probably going to be in a gown. So, but just state that, they're dressed appropriately, just so the examiner is aware that you're thinking about it. And this is also the time to talk about like general appearance of skin. If you notice there's jaundice just looking from afar, if there's obvious scarring, don't be shy to mention these things. I know it can be awkward that the patient is just standing there and you're saying, oh, they look appropriate for their age, or maybe they've mentioned they're 15 and they look like they're 40, and is it appropriate for me to say they don't look appropriate for their age? Say exactly what you see, because you need to be very objective. You need to make sure that you do have an objective approach to this entire thing. So that is number 6, your general inspection. So you've talked about their age, their dressing, and if they look like they're in distress, just general. So number 7, you're also, sorry, before I move on, no, sorry, number 7. My apologies. Hopefully this video won't be very long. Number 7, you're going to be making sure that just right after you've looked at the fact that they look like they're stable, look at how they're sitting. And this is a trick that I like to do to students. Make sure that the patient's legs are uncrossed and on the floor. You can, just to make sure you get this out of the way before you even do blood pressure, you don't have to think about it later. Make sure they are sitting back to the chair. Their feet are both planted on the floor and their legs are not crossed. Just because if their legs are crossed, then it's going to throw off your blood pressure. It might make it higher than it actually is. And also you don't want them dangling either. So there's 2 options that you have. If you have access to a stool where the patient is, because for instance, if the patient is sitting on a stretcher or a bed and they don't want to move, you can put their feet on a stool. The second option is to bring the patient down to a chair, or to lower the bed itself. So I guess there's like 3 options there, or to lower the bed itself, just to make sure that the patient's legs are flat on the floor. So that is part of number 7. The second part of number 7 is to, before you even get started on the vitals, ask the patient if they've had any caffeine, if they have smoked, or if they've done any exercise in the last 30 minutes. And that's just because, as you know, all those things are going to either increase your heart rate or increase your blood pressure, or I guess in this case of exercise, it can decrease your blood pressure if you've lost some fluid. But yeah, so you want to make sure that you've done all those things so that you've put your readings into context when you go and do your blood pressure and your pulse and all that. Okay, I know it's taking long to get to the actual vitals, but here we go. So now we're actually at the vitals. So number 8, you're going to go ahead and take the pulse. And so make sure that you do have your analog watch already on your hand. And you're going to first start by landmarking. So first thing is landmarking. So in case you don't know how to find the radial pulse, so you have your hand here, you have your thumb. Make sure you're on the side of the thumb. The reason I'm saying this is because it seems obvious to anybody who's in healthcare, anybody who's been doing this for a while, but it's not obvious to somebody who's new. And it's not stupid to not know that. You just don't know what you don't know. So you have your thumb. Fortunately, the radial pulse is well labeled, unlike many things in biology. And so you're going to be looking at the radial side where like your radial bone would be, right here, right? And so you're going to go to the wrist, right? Sorry, I'll switch it over. You're going to go to your wrist. And so you find here, come to the front. So you're going to go, I guess, slightly anteriorly, here, your anterior. You use 2 fingers and you put it right over there, okay? So not medial, not lateral. Oh, sorry. Medial, not lateral, not central. So you're very medial here, okay? And you take the pulse. So you're going to do both sides. Before you actually go ahead and take the pulse, you're going to put your hand, like you're going to palpate both sides at the same time. So you're having basically your hands like this on the person's pulse, and you're just going to feel for it for like 10 seconds, not long at all. And at that point, you're not commenting on rhythm or rate because you don't know that yet. So that would be an X from the examiner, right? All you're commenting on is quality. So you're saying that both sides are equal. So at least you know that bilaterally you have an equal pulse. And you can at that point note, is this a very strong pulse? Is it a very weak pulse? And the way we do that, you should know, is by using the 0 to 3 description. So if it's 0, that means the pulse is absent. If it's 1+, that means that it's there, but very faint. If it's 2+, that's exactly normal. That's exactly what you want a pulse to feel like. And if it's 3+, that means it's bounding. So it's a very strong pulse. So you're gonna have to feel, I guess, some different pulses to understand, or you can just really feel for a couple normal ones from your friends, and you'll know what a 2+ pulse feels like, okay? So that's before you even measure the pulse. Now you only use one of the patient's hands. You don't need to be palpating both of them. You're going to palpate one radial pulse, and you're going to do it for 30 seconds. However, you're not going to let the patient know, but you're going to tell the patient initially that you're checking the pulse for 1 minute, but you're only going to do so for 30 seconds. Pro tip, okay? And so when 30 seconds pass, so you've already put down that number in your head, you're then going to, without the patient knowing, continuing to palpate the pulse. You're going to look at the patient's respiration rate. And the reason that you're doing that is because when people are aware that their rest rate is being counted, they change the way they're breathing. Even me. That's why I suck at being an SP, because the minute that I know that they're doing the whole trick thing and they're starting to measure my rest rate, I start doing this. Because I want it to be so obvious that I'm breathing. So don't tell them that you're switching over from pulse to rest rate. Just go ahead and start measuring the respiratory rate halfway through. So now you've measured both. You should have noted both numbers in your head. Multiply both numbers by 2, and we're going to start by verbalizing to the examiner about the pulse. And so now you have your rhythm and your rate. So you would have been feeling for, is it within the normal rate? And normal rate is going to be anything from 60 to 100, Anything below 60, you're going to be bradycardic. Anything above 100 is going to be tachycardic, so too fast. And so you're going to explain, okay, this patient has normal normal rate. And then in regards to rhythm, you're looking for, was it consistent throughout? So in order to get an irregular rhythm, that would be something like atrial fibrillation, where like sometimes you have 2 seconds between a beat, sometimes you have 5 seconds between a beat, sometimes you have 10 seconds and 2 seconds again. But if every beat was like 2 seconds, 2 seconds, 2 seconds, then that is going to be a normal rhythm. So you're going to tell the examiner, okay, they had a regular pulse, and this was the rate. Done. So in terms of the respiratory rate, you're going to make sure that, I want to say that this one should be anything between 12 and 20. Your textbook or whatever you're referring to might say something a bit different, but anything between 12 and 20 should be okay. Anything less than 12, that would be bradypnea. I don't think I've ever used that word, but they'd be breathing too slow. Or I've only ever really used the word tachypnea. Otherwise, I think I just say that they're breathing too slow. That even sounded weird coming out. Okay, so otherwise, if it's above 20, then it's going to be tachypnea. And you can also comment on that point. Was it breathing shallow? You can talk about their position. Were they tripoding? Like, were they trying to gasp for air? So that's a good time to mention that as well. But you could have also done it initially when you were doing their general inspection. Okay, so now we're finally at the blood pressure. So that wraps up number 8. And so now we're moving on to number 9. You're going to be doing the blood pressure. Okay, so the blood pressure you're going to note is going to be 2 steps. So the first step, you're going to be estimating your systolic blood pressure using the radial pulse. And in your second step, you're going to be auscultating for an accurate blood pressure, so systolic and diastolic, using the diaphragm of your stethoscope. And so in step 1, in order to locate your brachial pulse, so I've already shown you how to find your radial pulse. So that's your thumb, come down, go in the front, just medially. That's where your, or you know what, am I saying that right? Well, by your thumb. I'm so sorry if that's not anatomically correct. I'm like trying to think of which side is like, but you get what I'm saying. Okay, and then so that's where your radial pulse is, but then you also need to make note where your brachial pulse is as well. And so a quick way to do this is get them to flex. Oh, so cool, so strong, right? So you flex, and then you're going to find where your tendon is for your biceps. You're going to, that one, you are going to go medial. You're going to go slightly medial, and so you're going to be in your antecubital fossa. And so once they stretch that out, you should be feeling for their brachial pulse. And so it should be pretty easy to find. I know some people get confused. I think some people think it's like right in the middle of their antecubital fossa. Some people think it's more of like more lateral, but no, it's going to be slightly medial to when you get them to flex where their bicep tendon would be. Okay, so like right here. Okay, and the reason that that's important to note is because you have your blood pressure cuff. So you have the cuff. I must have cleaned this in a really weird way. I'm so sorry, guys. Yikes. So you have your cuff, and you have you have this, and you're going to place that on their brachial artery. So you're going to look at the antecubital fossa. You're going to use 2 fingers just above the antecubital fossa, and right above that, where your brachial artery you palpated it to be, that's what you're going to line this line up with. So you're gonna put it on over right here and wrap it around and make sure it's nice and snug. And you're going to ask the patient, does that feel comfortable? And they're going to say yes or no, and then you can proceed. And then when you have that as well, once you have that securely on the patient, you're going to lock it in place. Actually, mine does not have a place to lock it in. That's really weird. But some people have a way to like lock it into their blood pressure cuff so that they don't have to hold this. I guess some people's are different. Yeah, mine is attached to my my gauge or my sphygmometer, whatever, like this part. Some people's are not, like different blood pressure cuffs, but whatever. So if you have the ones that are not attached, then you would just secure that in place so that you're not holding like multiple things at the same time. Okay. Another thing I wanted to show you, oh wow, this is taking a little bit longer, but I promise you this is still shorter than going to a class, right? So, okay, not too bad, okay? Another thing that people like often fumble with, so I want you to know how to use your blood pressure cuff properly so you're not like at your OSCE trying to figure out, do I go right, do I go left? Righty, tighty, lefty, loosey, okay? So if you see here, I'll have to show it to you at the side just because I have to have it facing me. But if I was to be holding this and I had this on a patient, I'm going to turn this dial. I'm going, or I guess valve. I'm going to turn the valve to the right, right? So in order to lock it, I'm turning it to the right. So you don't want to lock it too tight, by the way. You're going to just like ever so slightly lock it. And the reason why is once you go in, you want to start releasing some of the air. You don't want to be there like trying to like undo the valve. So just ever so slightly lock it. Okay, it's there. And then you can start like pumping up. Okay. And once you get to where you need to get to, then you ever so slightly, you start going left. Okay. And then that will bring the dial down. Okay. So you're not going to be like tightening it really tight and then like, you know, but with the valve ever so slightly so that you have control over how much air or how many millimeters of mercury you're going up or down by. Okay, so I hope that was clear. Again, righty tighty, you're going to close it on the right so that you can pump up. Okay, so it's going to start squeezing on the patient's arm. Once you get to the number that you want to get to, then you can start turning left ever so slightly. Okay, and then once you're finally done, you just go all the way left and release. Okay. Yeah, so you should be starting it within the position of righty tighty. So it should already be slightly tightened, ever so slightly. Again, I'm only stressing this just because people do it really tight and then they struggle to undo it, and then they're fumbling when they're actually doing it in front of the examiner. Okay, so done. So what do you need to do for the first step of your blood pressure? So now you've already put on the blood pressure cuff because you've already palpated for the brachial artery. So the first step is you're going to have your hand on the same arm that the patient that you're taking the blood pressure. You're going to have your 2 fingers on that radial pulse. And so you ask the patient also, before you get started, you ask the patient just to make this patient-centered. Sorry, I'm not trying to be sarcastic, but it's like a driving test. You want to do all the things, you say all the things. Which arm would you like me to use for your blood pressure? And then you stop. Okay, thank you. And so then you put it on. Is it snug? Okay, perfect. I'm going to go ahead and start my blood pressure. And I'm going to go ahead with my step 1 of taking the blood pressure. I'm going to put my finger on the radial pulse of the same arm where the blood pressure is placed. And I'm going to be feeling for when I'm going to increase the pressure of the blood pressure cuff until I notice that the radial pulse disappears. And then I'm going to decrease the pressure by 2 millimeters of mercury per heartbeat or per second. So you're going to basically be saying a script the entire time. And so it'll be a lot more smooth when I'm just doing it with my friend so that you can kind of see exactly what the script looked like. But so yeah, that's what you're doing. Put your hand or your finger on the pulse, same arm. You're going to inflate the cuff just rapidly, and you're going to feel for when you notice that pressure disappears. So you've done it rapidly, and then ever so slightly you're going to release. So remember, lefty loosey, you're going to release by 2 millimeters of mercury per heartbeat, and then you're going to continue feeling the pulse. Once you see that the pulse has returned, look at the dial, look at the gauge. Whatever number you notice that you felt that radial pulse again, that is your estimated systolic blood pressure. So now you're done step 1. Step 2 now, you're going to keep that number in mind. And then when you go to inflate the cuff the second time, you're going to be inflating 20 to 30 millimeters Hg above, or millimeters of mercury, sorry, above the number that you estimated. And so that's just going to ensure that you're in the auscultatory window. And you could also state this to your examiner: I'm going to be inflating the cuff 20 to 30 millimeters above the number that was estimated. And this is to ensure that I'm in the auscultatory window. Done. So you go ahead and you do that. So again, you make sure that you palpate for where your brachial artery is. And this is important because that's where you're going to be auscultating. You're going to be taking the diaphragm of your stethoscope, placing it just below the cuff, so right on your brachial artery, or sorry, their brachial artery, and then you're going to inflate the cuff as you're listening to this. And so initially you won't hear anything. You're going to inflate. You're going to bring it to, like, let's say the person you estimated their systolic to be 120. You bring it to 30 millimeters of mercury above that. So you bring it to 150. So initially you will not hear anything. You're going to slowly release, remember, ever so slightly, 2 millimeters of mercury every second or every heartbeat, so that you do not miss that first click, okay? That's why I'm stressing it. You're gonna release, 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 and then you're going to, even before you hear the clicking, I'm sorry, I'm wondering if this is even clear. Even before you hear the clicking, you're going to notice the dial on your gauge start to do this. Note that time, because shortly after that is when you should hear your first click, or your carotid cough sound. Okay, so you're going to see it like do this. It's kind of starting to bounce, and then you're going to start to hear it. You're going to start to hear it click, 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 and it's going to get louder, 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 and it's going to stay there for a minute. So when you hear that first click, note what that when you saw that click, because that is your systolic blood pressure. So you don't have to state it just yet. Just note it. And then you're going to continue to release. You're going to keep on hearing click, click, and you're going to keep on seeing the dial do this weird thing as it, like, like go up and down, up and down. And then finally, so make sure, again, you're doing this at 2 millimeters, like you're not doing this so slow, because if you do it too slow, you're going to notice that you might never actually hear the end of the click, or it's going to be very, very like drawn out. But you want to make sure that you're maintaining a good pace so that you actually get an accurate blood pressure reading for your diastolic. So again, you're releasing, 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 and then you're going to suddenly stop hearing the click. When you stop hearing the sound, that is your diastolic blood pressure. Okay, so congratulations. You're basically done your OSCE. All that's left is to verbalize what it is that you heard and if it's in the correct range. So you're going to tell them my diastolic was 120. My systolic was 120. My diastolic was 80. And so that is within normal range. And just again, understanding what is normal, what is not. So anything below 90 for systolic, that is going to be hypotensive, and anything below 60 for diastolic is going to be hypotensive. Anything above 139 is going to be considered hypertensive. Anything above 89 is going to be hypertensive as well. So I don't think they're going to ask you for pre-hypertension or anything. I think it's just, is it hypertensive, is it not? So if they do ask you for pre-hypertensive, it's between 130 and 139 for the systolic. But yeah, all of your patients will most likely be within normal range, just because, it's your first OSCE. They're not going to throw you off with anything. So most of these patients will have a regular pulse. They're going to have a normal blood pressure. They're going to have a breathing rate that's like, I don't know, between like 14 and 18. So no stress. Just make sure that you're verbalizing everything as you go along. And hopefully you learned something from this. Make sure you go ahead and you try this out yourself. You do not want to be there fumbling with your blood pressure cuff on the day of. So learn to have that down pat. Righty-tighty, lefty-loosey, okay? And yeah, hopefully you are able to kill, or no. We're reindeer here. You're gonna slay those OSCEs and your vital taking. So yeah, go ahead and slay it. And hopefully you check out my other video on how to take a history as well. See ya, bye.